So what are the steps? The first one is pluripotent hematopoietic stem cells. As we said, we have stem cells in different locations, and these stem cells are such that they can produce any type of cells, any type of cells that are present in our body. But hematopoietic stem cells, these are one kind of stem cells that are committed to produce blood cells. That's why the name is hematopoietic. Means this will produce, this type of stem cell is destined for blood cell production. And they are located in, obviously, they should be located in bone marrows. Okay? And to initiate erythropoiesis, they should be converted into BFU, burst forming unit erythrocytes. These are of different kinds. These are of different kinds. When we want to produce erythrocytes, then this variety will come, BFU, E. E stands for erythrocytes. They are committed to produce only erythrocytes. They cannot go back to the original form PHSC, because from PHSC, different kinds of blast forming units can be produced. But here it is destined for erythropoiesis, means RBC production. And this conversion, for this conversion, you see some factors are needed. What are these? Very important. These are interleukin. These are interleukin. There are several kinds of interleukin. Only interleukin 1, 6 and 3 will be involved to convert, to differentiate pluripotent hematopoietic stem cell into BFUE. Another thing is here required, another two factors are also required, that are GM-CSF and erythropoietin. You have heard the name erythropoietin. GM, granulocyte macrophage colony stimulating factor. Okay, so there will be one colony for granulocytes and another colony for macrophages, and they will produce stimulation for the formation of a colony, and that should be for erythropoiesis, colony of erythrocytes. Okay, and erythropoietin we will discuss in detail, very important regulatory hormone that governs or that controls erythropoiesis. Then this BFE, burst forming unit, they divide into myeloid series, another is lymphoid series. So lymphoid series, from lymphoid series, lymphocyte will be formed, and from granulocyte series, erythroid series, granulocytes, RBCs, monocytes, platelets, these will be formed. So BFUE, these are actually erythroid series, myeloid series. This comes under myeloid series. From these, erythrocytes can be produced. Granulocytes like neutrophil, eosinophil, these can be produced, and thrombocytes, this can be produced. So there will be three different types. If it is megakaryocyte, we know from megakaryocyte thrombocytes are formed. So one series will produce megakaryocyte, one series will produce erythrocytes, one series will produce granulocytes. So we are interested in erythroid series, means they will form erythrocytes. You see, the first step, it involves rapid mitosis. From PSSC, huge numbers of BFUE is produced. Now, BFU cells will produce enormous number of CFUE. And during this conversion, actually, during this mitotic division, there are some factors like, see, cell is dividing. So what is required for division of this? Proteins are required. And DNAs are required. And for the formation of DNA, without the supply of DNA, the cell cannot multiply. They cannot undergo mitosis, cell division. So DNA supply should be adequate. And we know some dietary constituents are very much essential for formation of DNA. And what are these? Vitamin B12 and folic acid. Vitamin B12 and folic acid, so they are very much essential. We will discuss in detail. Then CFU, once CFU is produced, again those factors, not IL-1, not IL-6, not the other two factors, colony stimulating factors will come into action, and erythropoietin, like that part, like this step, here also it will participate, erythropoietin. Erythropoietin not only favors multiplication but also favors modification. The cells that are formed, they will undergo modification, differentiation. So this differentiation is also helped by erythropoietin. Now the CFU will be converted into, by these factors, into pro-erythroblast, or by another system of nomenclature. This system is American nomenclature. Another system of nomenclature is there. They don't say this is pro-erythroblast. They will say the British nomenclature is pro-erythroblast. That is pro-erythroblast, like this. This is normoblast. From pro-erythroblast, this is the next step is early normoblast. This is as per British nomenclature, but here it is not normoblast, it is erythroblast. See, so all these are blast forming cells, blast cells. Now this pro-erythroblast, they also can divide, and they will divide up to these stages. All cells, all steps, the cells of this stage, they can divide. But when the cells, these are transformed, these cells are transformed, there will not be any mitotic activity. So number will not be increased. So here what will happen? They will undergo maturation by the process of differentiation. By the process of differentiation, they will undergo maturation. Now this intermediate normoblast, in this phase, hemoglobin starts to appear. So here you will not get any hemoglobin, here you will not get any hemoglobin, but hemoglobin starts appearing from intermediate normoblast. Okay? one thing you will observe during different stages of development, the size of the different cells produced are gradually decreasing. Size will be gradually decreased. And initially the nucleus was big, and within the nucleus there were a good number of nuclei. As it proceeds, the size of the nucleus will be decreasing and number of nuclei will also be decreasing. So this is another change you will be noticing. You will be noticing there is appearance of hemoglobin. Okay, at one time in one stage you will find the nucleus or the nuclear material, chromatin, they are condensed into a dot-like structure. And after that, this will come out of the cell. This will come out of the cell, and that's why the RBC become non-nucleated. Okay, some other organs, as I said yesterday, the endoplasmic reticulum, no use of endoplasmic reticulum since nucleus is not there, so no use of endoplasmic reticulum in the cell, in this cell, so these will also be eliminated. There will not be any mitochondria, so this will be eliminated from the cell. So as a result, consequence is their size will be gradually decreased. We will see how these size is reduced. See, no, not this one. Oh, the slide lost. See, in pro-erythroblast, the size was 15 to 20 micron. Okay, in the next step, it came down to 14 to 17 micron. In the next step, 10 to 15 micron. And the next step, 7 to almost coming closer to RBC. It is, RBC diameter is 7.2. Okay. Next step is reticulocyte formation. Reticulocyte. And it is slightly bigger than the RBCs. If RBC is 7.2, it may be 7.8 to 8. 7.8 micron to 8 micron. This reticulocyte, still this reticulocyte remains in bone marrow. But depending on the crisis in the blood, crisis means, see, if there is anemia, they will rapidly come out of the bone marrow. They will come out of the bone marrow. And in the blood, normally you won't get more than 1% reticulocyte. But in these circumstances, when the patient is anemic, the crisis is more. So in that case, more reticulocyte will be coming. So reticulocyte indicates, more reticulocyte indicates my bone marrow activity is much more. Okay, so we getting the number of reticulocytes in the blood, we can assume the activity of the bone marrow. Pycnotic nucleus. So this is the pycnotic nucleus. Normal nucleus, number of nuclei is many, so gradually it becomes condensed. It becomes condensed, and ultimately this will be fragmented and eliminated from the cell. This is called pycnosis. In reticulocyte, you will get, when you will study histologically, reticulum will be there. But after some time, 3 or 4 days, this will go. See, it makes up 0.5 to 2% of all erythrocytes. And vital staining is required. It is a special stain, not by Leishman stain you can identify this. So by special stain only, so that reticulum are seen. So for that purpose you have to use vital stain. And when blood contains more than 2% of reticulocyte, then we call it reticulocytosis. When there is hyperactivity of the bone marrow, then only it happens. So what is there in reticulocyte? It has no nucleus, has no organelle, is slightly larger than the mature RBC, is not biconcave. Still it has not taken the shape of normal or mature RBC. In severe anemia, many of these cells are released into blood prematurely. Okay, we call it reticulocyte response. Normally 1% circulating blood are reticulocytes. Okay, mature erythrocyte ranges from 7 to 8 micron, but average size is 7.2. Okay, it is having high hemoglobin. In which stage hemoglobin starts to appear? Intermediate. In this stage. Polychromasia, the term polychromasia, these cells are, these precursor cells, means RBC precursors, they are bigger in size. And presence of this type of cell in blood smear, in blood is abnormal. As a result, they will develop, but their size will be, in the blood, this RBC size will be bigger, macrocytic. We'll discuss different morphological, when different pathological condition, the morphology, size of the RBCs are changed. Epignosis appears in this stage. So this is about different stages. And how much time is required for erythropoiesis? 21 days it requires from this stage to this stage. But normally we will consider erythropoiesis takes only 7 days. From which step? From pro-erythroblast to erythrocyte. Pro-erythroblast to this, it takes 5 days. From here to here, it takes 5 days. And from here to here, the last stage requires 2 days. So total 7 days. Now, important aspect. Why there will be erythropoiesis? Before coming to this, I will ask, for survival of the cellular activity, cellular function, the primary requirement of the cell is what? Energy. Without energy, it can't do anything. So, where from the cell will derive this energy? From oxidation of foodstuff. For oxidation, so if I need energy, then my food, nutrients that has entered into the cell, that has to be oxidized. Okay, by different pathways, glycolysis, TC cycle, oxidative phosphorylation, beta oxidation, whatever the pathway is. So I have to oxidize this foodstuff. So for oxidation, what is needed? What is needed for oxidation of foodstuff? Oxygen. Without oxidation is not possible. Without oxidation is not possible. When you will stop the supply of oxygen to the cell, what will happen to the cell? The cell will die. Why? It is unable to produce the energy. So to force their survival, oxygen is needed. Oxygen is needed. Who is supplying? Blood is supplying. Blood is getting oxygen from the atmosphere, and this oxygen is entering into the blood in lung, then it is carried to the cells. From this oxygen is utilized by the cell. So when there is insufficient supply of oxygen to the cell, what is this condition called? Hypoxia. We call it hypoxia. So when there will be less supply of oxygen to the cell will feel hypoxic. And consequence, less production of energy, consequence, less activity in the cell. If it is in muscles, you will be unable to work properly, you will be feeling fatigue, you will be feeling weakness, tired. Okay, so a lot of changes will be coming into your body because of short supply of oxygen to the tissue. So because oxygen is filling hypoxia. This hypoxic feeling, this is lack of oxygen supply to the tissues, it generates stimulation. It generates, means hypoxia stimulates a condition which will prevent this condition, which will rectify this condition. So it will increase RBC production. This hypoxia will increase RBC production by the bone marrow cells. Okay? How? How hypoxia help this condition? Hello? There is a sensor. There is a sensor in our body that senses hypoxia is going on. Where lies these sensors? These sensors lie in kidney, in liver. That's why when kidney is damaged, you cannot sense oxygen, so you will suffer anemia. When liver is damaged, you can't sense. So what will happen? Anemia will be there. In the kidney patient, say CKD patients, CKD means chronic kidney disease or chronic renal disease, kidney disease or renal disease. In this case, kidney glomerulus are kidneys, lot of glomerulus are there, some glomerulus are gradually wasted. They are replaced by fibrotic cells. So kidney gradually shrinks. They are useless. The filtration cannot take place. Huh? It is a gradual process. I can't hear.
So the glomerulus is replaced by, in the kidney, the glomerulus is replaced by which cells?
Coming. Then where these sensors are located? Okay, these are located in, tell me, the structure of nephron, glomerulus, afferent arteriole, glomerular top capillaries, then efferent arteriole, and capsule. After that, proximal convoluted tubule, then loop of Henle, then distal convoluted tubule, then it goes to collecting tubule. So if you take a cross section of kidney and you stain it, see under microscope, you will find lot of this type of structure, elongated, that means longitudinal section of these tubules. You will find round sections. These are actually cross section of these tubules. So around these tubules, there are capillaries. Around this tubule, there are capillaries. Because from this tubule, something will be absorbed. And absorbed in what? In the blood vessel capillaries. So in between the tubules and these capillaries, in between there are some cells. These are called interstitial cells. And these interstitial cells, they can sense that blood is having less oxygen. We know. See, your blood maximal, suppose you are an adult man and you have 15 gram of hemoglobin per 100 ml of blood, how much oxygen you can carry? 20 ml per 100 ml. We have calculated the other day. 1.34 into amount of hemoglobin. So that is the amount of oxygen we can carry per 100 ml of blood. Okay. So in this condition, hemoglobin can carry, but my lung is unable to supply that much oxygen. So hemoglobin molecule becomes less saturated. It is not transferring or transporting the amount it actually can. Less than this. So what happens during COVID, what you did? You attached one machine in your finger, then you read some number is displayed, 91%, 92%. These are hemoglobin saturation of hemoglobin with oxygen. If it is 90%, the capacity is 100%. All the heme moieties, they can attach to the oxygen. But in this case, all heme moieties are not saturated. Only part of these are saturated. This is one, there lies one sensor. What is there in, what is some mesangial cells? Means artery is entering within the capsule and forming capillaries, and over the capillaries, this junction, one tubule is passing through these two arms. Okay, so some cells are there in between. The junction of afferent and efferent and the tubule passing through this, so in between there are cells. These are called mesangial cells. So the blood that is passing through the afferent arteriole, these cells can sense what is the amount of oxygen. Oh, it is hypoxic. So let's release something. What is this? REF, renal erythropoietic factor. And this is released only when oxygen is less in blood, means during hypoxia. So hypoxic condition stimulates this cell, not only these cells, the interstitial cells also. So they will produce, here it will produce REF and there it will produce directly a substance called erythropoietin, a hormone. Okay, so there it will produce erythropoietin, here it will produce erythropoietic factor. Now this erythropoietic factor will convert one globulin, one alpha globulin. There are different types of alpha globulin. One alpha globulin is there in the plasma, that is erythropoietinogen. Erythropoietinogen, inactive form. So this REF will convert this this erythropoietinogen into erythropoietin. Okay, so now erythropoietin is formed directly from interstitial cells and in the glomerulus through REF. Okay, so now this erythropoietin is asset. Is asset for what? For stimulation of erythropoiesis. And this erythropoietin, 85% of the erythropoietin comes from kidney. So now you can think, if kidney is gone, if there is nephrectomy, one kidney for some reason it has to be eliminated. Okay, so in that case what may happen? Definitely we will be anemic because erythropoietin will not be secreted and it will not stimulate for erythropoiesis. Stimulation, there will be lack of stimulation for erythropoiesis. Another source of erythropoietin is liver. I can find this maybe where it is got. See this. Kidney glomerular mesangial cells, they secrete REF. Okay? This REF, this conversion is due to hypoxia. Hypoxia causes conversion of REF release from kidney. So this REF converts erythropoietinogen into erythropoietin. Now this will participate in for conversion of stem cells into proerythroblast. Okay? And liver is another source of erythropoietin. Liver where? There were some images. There, if you take a cross section of this, these are hepatic globules. At the center, there is a canal. This is called hepatic central vein. From the central vein, series of hepatocytes are arranged like the spokes of cycle. Okay? These are hepatocytes. In between the columns of hepatocytes, there is a space. These spaces are called sinusoids. These sinusoids are filled up with blood. This blood is coming from intestine, taking absorbed foods, and also from the spleen. All these are drained into these sinusoids. At the corner of these, there are three types of vessels. These vessels are called triads. These vessels are called triad. Three types of. One is bile, one carries bile, another carries arterial blood, and another carries arterial, another is arterial vein. Okay? So this venous blood, suppose this is the vein. And this vein bringing blood from where? Intestine and spleen, and entering into the Two hepatic veins are there, superior and inferior. They join together and drains their blood into this. This blood is again drained into this. And then in this, when this blood are in sinusoids, now lot of exchanges takes place. Because this blood contains so many things that are absorbed from intestine, digested foods, harmful substances. That's why some macrophages, you will find some macrophages, Kupffer cells. They kills the pathogens which are absorbed from intestine. So these will be killed by the Kupffer cells, macrophage cells. And the blood entering here, it may have less oxygen because of hypoxia. So these will be sensed by these hepatocytes. When they sense this there is less oxygen, so immediately it starts producing erythropoietin. Now this is another source of erythropoietin. Liver is another source of erythropoietin. Now this erythropoietin stimulates this cell to form this cell, stimulates these cells to form these cells, and they also help in transformation of these cells to erythrocytes. Division as well as transformation. Both are helped by erythropoietin. And it also stimulates early release of reticulocyte into the circulation. So erythropoietin also determines when this will be. If there is an urgency, it will take less time. If sufficient oxygen is there, this transformation will be made slowly. So these are the functions of erythropoietin. So it is the erythropoietin that regulates how the erythropoiesis will go on, whether at a faster speed or with a lower speed. The amount of, normally what happens, amount of RBCs destroyed by various means, these are destroyed. Lifespan is 140 days. Some cell will be dying today, some cell will be dying tomorrow. Okay, so these are to be replaced. So these are replaced by erythropoiesis. So amount of cells damaged, amount of cell is created. This is rate. When there is hypoxia, the amount of production will be more. Okay. And this is one factor, as I said. So one of the erythropoietin is one of the most important factor that controls erythropoiesis. Next, other than erythropoiesis, what is there? This is interleukin 1, 2, 1, 3 and 6 and GM-CSF. These are the essential factors that will stimulate erythropoiesis. And one interesting thing, some hormones are also important for erythropoiesis. Why rate of erythropoiesis is less among women? Their amount is always less. But before puberty, there is no difference between a boy and girl in erythrocyte count. Normal. Whatever the amount a boy is having before puberty, the same amount is having by a girl. But when a girl starts or falls in adolescent period, picture is changing. They are producing less amount of RBCs. Why? You are producing more.
So because that closure of that something happens at 16 years of age in females.
What happens?
Because of the closure, I don't know the exact that because of the closure.
Anybody can?
Testosterone helps in electrolysis. Testosterone helps in electrolysis.
Before puberty, there was no gonadal hormones. No estrogen, no progesterone. So once a girl from puberty enters in adolescence, so she starts menstruating. Or why menstruation starts? Because some changes take place in the ovaries. Okay, so estrogen and progesterone both make changes in the uterine endometrium. And this cycle, endometrial cycle, goes on every month. Okay, so estrogen is produced, and this estrogen actually inhibits erythropoiesis, whereas androgen, testosterone, they stimulate. So because of this difference of reproductive hormones, they produce less RBCs, you produce relatively more. The question may come, short question may come, so this is important. See, these are the factors. They will increase erythropoiesis and it will decrease erythropoiesis. What is there? Estrogen. Estrogen decreases synthesis of globin and depressing erythropoietin response. Erythropoietin response, the way a female should respond to erythropoietin, they are not, because this is partially inhibited by estrogen. Whereas, say thyroxine. Thyroxine favors erythropoiesis. How? In hyperthyroidism and hypothyroidism, you will find changes in the body. Those who are suffering from hypothyroidism, they produce less amount of T3, T4. Though pituitary is secreting high amount of TSH, it is trying to stimulate the thyroid gland to produce T3, T4 and T3, but it is unable to produce this thing. And this condition is, if you undergo a test, T3, T4 and TSH, you will find if the patient is suffering from hypothyroidism, her TSH level will be high, more than normal, but T3, T4 will be subnormal. So it indicates the patient is suffering from hypothyroidism. So releasing less amount of T3 and T4, what makes the difference? T3, T4 helps in oxidation of foodstuff. Oxidation of foodstuff. Since there is less T3 and T4, there will be less catabolism in your body, less heat production. But you have taken food, but all these foods are not converted into energy. So, rest of the amount which you have not used, that will be accumulated in my body as fat. That's why those who are hypothyroid, suffering hypothyroidism, they accumulate fat in their body, they gradually become obese. On the contrary, if somebody is suffering from hyperthyroidism, means here more T3 and T4 will be produced. So they will what more oxidation, no more catabolic process will go on, and they are lean and thin, and their body is always hot. It will, when you will be touching up with that patient, you are having fever, because catabolic process is going on at a faster speed. So deposited things are actually utilized for this conversion, for oxidation, for generation of heat. So here we can see those, in case of thyrotoxicosis, means more T3, T4, there is increased erythropoiesis. Why? Because you are oxidizing, no, at a faster rate. For that purpose, you have to supply more oxygen to the tissues. So who will carry this oxygen to this? Hemoglobin. So its production has to be increased. So how it can be increased? By stimulating erythropoiesis. So this is how thyroid hormone helps erythropoiesis. And see, another hormone is there. What is this? ACTase. How it helps erythropoiesis? ACTase. What is ACTase? Adrenocorticotrophic hormone. What is its function? What is its target cell? All hormones are having target cell. No? So ACTase has full form. What is the full form of ACTase? Adrenocorticotrophic hormone. That means it will target adrenal cortex. We know from adrenal cortex so many hormones are produced. Group of three group of hormones are produced. One group is glucocorticoids. They are involved in carbohydrate metabolism. One group is mineralocorticoids. They are involved in mineral metabolism. Another group is sex corticoids. It can also produce androgen, estrogen, progesterone. They can also produce, but at a lesser amount. Okay, so ACTase stimulates adrenal cortex. Adrenal cortex will produce more androgen, and this androgen will stimulate erythropoiesis. This is the mode of action. Okay, now it is clear to you. Prolactin is secreted by the anterior pituitary during breast development and during milk formation. They are not involved in milk ejection. Oxytocin is used in milk ejection. So when prolactin is released, it is seen the RBC formation is also increased. So in this way, plus steroids. Steroids are androgens. So they will increase erythropoiesis. Moreover, some nucleotides like cyclic AMP, NAD, NADPase, they also stimulate erythropoiesis. Vasoconstrictor drugs, the blood vessels, all the arterial blood vessels, cross section of a blood vessel. So you will find 3 layers. This is the layer of endothelial cell. The inner surface is very smooth, single layer of epithelial cells. Okay? And outside this is the muscular layer. Outside, and this is tunica media, middle one is tunica media, and this layer is tunica interna. Tunica interna. And this exterior cell layer, they are made up of collagen elastin. So that it has the capacity up to like elastic expansion and it is not tear. When pressure is there, we increase pressure, it is not usually tear. So this layer, the middle layer, they are made up of muscles, smooth muscles. These muscles are circularly arranged. Muscles are circularly arranged like spring. So when these muscles are stimulated by the vasoconstrictor drugs, so they will cause constriction of these muscles, so the lumen will be narrowed. So now lumen is narrow, so it is creating resistance. So blood will be having have to face this resistance, means there will be increase in pressure. Okay, so if there is peripheral resistance, there will be increase in pressure, decrease in flow. There are, now your practical class, no? So I'll take 5 minutes to 6 minutes. Nutritional factors. There are nutritional factors that control erythropoiesis. We know hemoglobin is made up of heme and globin. Globin is protein, and these proteins are made up of amino acids, and for this we need lot of essential amino acids. Where from this will come? So we have to take protein. So if there is less supply of protein to the body, if you take less dietary protein, so you are unable to supply those amino acids, so globin formation will not be there. So erythropoiesis will be reduced. Similarly, two other important factors, vitamin B12 and folic acid. These two nutritional factors are very important. Iron, very important, otherwise how hemoglobin will be formed? Heme will be formed. And for formation of heme, some other microelements are needed, like manganese, copper, nickel. So these are also essential for hemoglobin synthesis. So unless you have these microelements in your diet, so your erythropoiesis is going to suffer. See how vitamin B12, it is also called extrinsic factor. Deficiency of vitamin B12 produces an anemia. And what is the name? This is called pernicious anemia. This is called pernicious anemia. And vitamin B12 is such that if you take it through food, it cannot be easily absorbed. It cannot be easily absorbed. Somebody has to bind with this vitamin B12. Vitamin B12 is very essential. Without vitamin B12, DNA will not be formed. Without DNA, there will not be cell division. So there will not be any erythropoiesis. So vitamin B12 is essential. So this vitamin B12 has to be absorbed. So how this is absorbed? This food vitamin B12, when it comes to the stomach at the inner surface, there are some foldings. Suppose this is one such folding. Gastric pit. There are different types of cells. One type of cell produces hydrochloric acid. In the stomach, hydrochloric acid form, and they are called parietal cell or oxyntic cell. Parietal cell or oxyntic, they produce hydrochloric acid. Another variety of cell is there. This is called peptic cell. They produce pepsin for digestion of proteins. And this cell, opsyntic cell or parietal cells, in addition to liberation of hydrochloric acid, they produce one important thing that is called intrinsic factor, IF, intrinsic factor. Without this intrinsic factor, vitamin B12 absorption will not be there. You are eating vitamin B12, but this will not be absorbed. This is absorbed from the ileum, small intestine, ileum, just before the part of large intestine. So from that part, it is absorbed. So somebody has to take this vitamin B12 from stomach to those parts. Who will do this function? This IF. It will combine with this IF and form a complex, and this complex cannot be broken by any digestive enzymes. So this IF plus vitamin B12 this complex from stomach from here it will go to ileum, and here it will be released, will enter into the enterocyte. And from there it will be passing through the blood to the kidney and liver, where they will be stored. And from there they will be transferred to the bone marrows. Okay. So without vitamin B12, erythropoiesis will not be possible because of absence of intrinsic factor. You may suffer. You are eating vitamin B12, but you are not getting intrinsic factor. Why you are not getting? Because the wall, these parietal cells, your immune system, you have produced some immune bodies which are taking these cells, parietal cells, as foreign body. So it is destroying these parietal cells. As a result, no IF will be produced, so you will be suffering anemia, pernicious anemia.
Why the immune system is destroying?
Because immune bodies, it happens, it is a disease. Like our immune body is destroying our kidney, lupus nephritis. It may destroy, this immune body can target my skin. So such immune bodies are destructive in nature. Say some myeloid cells, myeloma, multiple myeloma disease. So it is producing these cells are destroying the spinal cord, destroying liver, kidney. So those who are having multiple myeloma, their spinal cord will be damaging the spinal cord, as vertebral column as well as the kidney. There are some, if stomach is operated for ulceration, so if there is stomach ulcer, IF formation will be less. If stomach is operated for ulceration or for some other reason, so there will be less formation of erythropoietin, less formation of IF. So one question comes. The question is Cassell's hemopoietic factor. What are Cassell's? This question may come in your exam also. So Cassell's hemopoietic principle or Cassell's hemopoietic factor. These are intrinsic factor plus vitamin B12 and folic acid. Folic acid is also needed for DNA biosynthesis. And this folic acid is essential for conversion of vitamin B12 is needed for conversion of folic acid into folinic acid, which is one of the component needed in DNA synthesis. So both are needed, vitamin B12 as well as folic acid. So vitamin B12, folic acid together with intrinsic factor are called together Cassell's hemopoietic principle. There is another external factors. Among these, the external factor, so this IF is produced by the cell. So that's why it is internal factor. Whereas vitamin B12 and folic acid are coming from outside. So for this reason, these are external factors. So deficiency of both, either folic acid or vitamin B12 can produce anemia. Tomorrow we will discuss anemia. So this will be discussed in 2 sessions. One is there is 3 hours discussion period. What is that? ECE. During ECE program, our topic is anemia. So before that, there is one theory class. I will discuss anemia here also. So these are the factors. All the factors I have already discussed. So tomorrow we will be discussing anemia. So regarding anemia, the question comes. Problem will be given. A patient is having such and such things. These are the physical symptoms. These are the signs. So on clinical investigation, it is found by that hemoglobin concentration is less, erythrocyte count is less, MCB, PCB, MCS, these are less. So what is the diagnosis? We will be telling this is anemia. Patient is having pallor. Pallor is what? Pale conjunctiva. Okay. So the nail, if you judge the nail, if the nail is curved, not this way, but this way, boat-shaped nail, it indicates the patient is suffering from iron deficiency. There is sign of iron deficiency in tongue. Tongue becomes reddish, angry. Okay, lung becomes smooth, but it is not normally smooth. It is rough because of taste buds. But here the taste buds, in such case, taste buds will be atrophied. So it becomes smooth. Okay, there may be some other signs. So this way we will be able to diagnose anemia, and what type of anemia, that also can be diagnosed.